Good evening and welcome to the final session of the Royal College of Surgeons of England's regional representative events for this session. We've had some very good evenings and some very interesting speakers over the last few weeks, but I think we've probably surpassed ourselves this evening. This last session is entitled Getting It Right Next Time, and I was just saying that I hope there isn't a next time, but there may be. We have four great speakers, and I'm very grateful to all four of them for giving up their time. The first should need no introduction to you. Neil Mortensen, Professor Mortensen, your president. Ravi Mahajan is the president of our neighbouring college, Royal College of Surgeons of Royal College of Anaesthetists. Hugh McCaughey is from NHS England. He's the National Director of Improvement at NHS England, despite being from Northern Ireland. And Josh Burke is the president of ASIT, the Association of Surgeons in Training. So we're going to go straight into the session with presentations from each of our speakers. And unless you have any really pressing questions, I'm going to leave your questions to the end of the discussion, because I think that all four will have some common themes. And they'll probably be able to lend themselves to your questions together. So I'd like to introduce Neil Mortensen. Take it away, President.
Well, hello everybody, and thanks very much for joining us. I'm going to set the scene. I'm going to show some pretty slides. What actually we want is lots of discussion this evening, but we'll get the ball rolling. I guess getting it right next time is just not all of the picture, because even if we get through the second wave, that's not the end of the problem, and we'll all be talking about that in due course. Next slide, please. So here's a big mountain to climb. We'll describe some of it, we'll be talking about it, we'll be seeing if we can find ways of overcoming the massive problems we have ahead of us. Next, please. So we thought we'd done okay with the first wave, and now we've got the second wave, and that's more complicated because already the beds are full, because we've restored elective and other acute medical and chronic medical services, and now we're under a bit of a squeeze, and keeping elective surgery going in those circumstances is pretty tricky. Next, please. So this is the size of the mountain, 4.35 million on a waiting list. And as you can see there, over nearly 1.75 million people waiting longer than 18 weeks for treatment. It's a massive, massive backlog, and it's pretty difficult to see how we can easily get a handle on it. But we'll be discussing that. Next, please. I think one of the things we have found is that maybe the risk of surgery is not quite as bad as we thought it was going to be. Certainly the early COVID surge data suggested a 20% mortality for those with COVID having urgent surgery. The most recent report from COVID surgery, looking at COVID-light pathways, shows that pulmonary complications, ITU admissions, and deaths were comparable to the previous year. So if you're lucky enough, in inverted commas, to go through a COVID-like pathway, you don't have an adverse outcome. This is comforting, and this hasn't been published yet, but there's a new massive HES-based data study. You can see there 50,000 patients compared with 2019, 2020, emergency general surgery, high risk. And obviously, again, if you have COVID, your mortality is significantly elevated, around 17%. But overall, the 30-day mortality was very similar between the two groups. And for electives, whilst there was a big caseload reduction, again, a big impact on training there was no overall increase in mortality, 1% versus 1% in the previous similar period. In 2019. This hasn't been published yet, but again, this is comforting. This is telling us that if we try really hard to provide those appropriate safe pathways, we can provide safe surgery and anesthesia. Next, please. We're going to be talking about the independent sector a bit. In our survey completed in September, around 60% of surgeons were able to access independent sector capacity. Obviously, some said they couldn't. Next, please. And then, of course, the major effect has been with that reduced capacity, with that reduced numbers of cases going through, the lack of elective activity has meant that it's been really difficult for our trainees. What I call the collateral damage of the pandemic. And I think maybe, Josh, you could help me decide whether or not we could call this the COVID generation of surgeons. It's not meant to be pejorative. It's meant to actually describe how tough it's been for them. Next, please. There's been some good news. Cancer surgery largely kept pace with demand. Cardiac and emergency surgery has continued. We're now getting testing for all frontline staff being rolled out, which is fantastic. We've been calling for that for some time. We've learned more about infection prevention and control in these special circumstances. We know much more about aerosol generating procedures than we did before. We've pretty quickly cottoned on to the wider use of virtual consults, and the ability for local groups to solve their own problems has been absolutely liberating. Local energy and inventiveness, quick, rapid responses to problems. Many of our colleagues have found that a fantastic blessing. Next, please. All the way through, and I know my regional colleagues have seen this slide already, we've been calling for all the way along ring-fence COVID light surgical beds. We'll be coming to how that's manifested in the future. We talked about testing. We've talked about COVID light sites using the independent sector, as well as those sites within trusts, which can be kept COVID light, an equitable allocation of nursing staff. Important to mention this, one of the successful trusts, Croydon, for example, they've actually completely divided their staff into two. There are those who work in the emergency part of the hospital, but they've kept completely separately nursing staff, surgical staff, anesthetic staff, completely separately for the continuation of surgery and other elective activity. And again, trainees. Next, please. So will we ever catch up? And there's the vaccine, which has been really exciting this last week. Next, please. But of course, as we've already said, there's this tension between the emergency and elective surgery during winter, services during winter, and so there's no hope of it getting better, or we're beginning to get back to normal by then. Next, please. And in the spring even, next slide, I think, the recovery is going to be very slow. The mountain will be bigger. We need some kind of strategic national plan, what we're calling a New Deal. Next, please. We may, in discussion, talk about some of the radical solutions that are being proposed: surgical hubs and beds, the use of facilities 24 hours a day, 7 days a week, flexible job plans, smaller portfolios and better quality maybe for surgeons, better IT and surgical technology, much more use of day case surgery and particularly local anesthesia perhaps where it's possible, and better care of our staff, because all these things aren't going to be possible without having a well-motivated, happy group of people delivering it. Premiums for job satisfaction. Next, please. Nearly there. Tomorrow, there's going to be a major announcement about integrated care systems. Some of my older colleagues will remember something called regional health authorities. It's not quite that, but it's very like it, I can tell you. As you know, each individual trust up until now has been in a situation where we've been competing with each other for patient, staff, and all the rest of it. And we've learned during the pandemic that we need to share, we need to have partnerships, we need to have networks. So the integrated care systems which are working in London, or at least in some places in London, which are being proposed, may become law and may become the model throughout the country. And what will the, if you like, effect of this be? It's going to be the end of a competitive health service. It's going to usher in a new era of local solutions, cooperation and networks. And the providers will be asked to go into partnership with each other and collaborate with each other. I personally think this sounds very exciting, very promising. Maybe there will be a new deal for surgery and trainees. I was interested to see in the Chancellor's announcement, extra 3 billion for the NHS, 280 million for Health Education England, 2021 to 22, to support the training and retention of the NHS workforce. So you can be sure we're going to be lobbying like crazy to see that some of that comes towards keeping elective surgery going, particularly for our trainees. And I think that was my last slide. Apart from that very nice picture looking over the horizon. So thank you all very much. And it's absolutely my delight to ask Ravi to speak next. Ravi and I haven't really properly met. We've only actually met virtually because I started as president during the pandemic. Ravi is actually speaking from India by the miracles of modern technology. Ravi, you're very welcome to the College of Surgeons. I hope I can actually physically welcome you to our new building one day. Thank you, Ravi.
That will be great, Neil. Thank you very much, and thank you for inviting me to your webinar of such an important topic. And thank you, Neil, for setting the scene so well. So yes, we've seen the mountain, and we've seen why this mountain is there now and what made it develop. If I take you back to March this year, when critical care capacity was getting to the point where we could not have any more patients admitted to critical care, we had to create space, and theaters became the obvious place, and theaters were, all theater activity stopped, and also staff, especially anesthetic staff, got redeployed to support critical care. So if we don't want to be in the same situation again, which we certainly don't want to be, as you've heard during this second speak, we are trying to carry on with the elective work alongside managing critical care. We got to be working slightly differently than what we did the last time. And if I could look at things under 4 headings or 4 S's, space, staff, supplies, and systems, and then take them one by one. And I think you've heard already from Neil how important it is to have separate or segregated areas for COVID light work and COVID heavy work. Contamination of infection or infected material certainly brings up its own challenges and challenges the elective work. So if we want to carry on with the elective work, which is what we want to do, I think that is quite an important piece of work that we need to think about. In terms of supplies, you would remember newspaper articles regarding PPE, regarding ventilators, the drug shortages, and all those kind of things. I'm sure we are over those, and we hear from NHSE all the time that we've got plenty of stocks, but we do need to make sure that our stockpile is not based on the calculation of the first surge, because the theatre activity actually stopped during first surge. So if we are thinking of theatre activity alongside enhanced critical care and COVID-related activity, the stockpiles need to be actually larger than the first time. We have been reassured that that's the case, but I think that's something we need to bear in mind. In terms of systems, and I'm sure we'll hear more about that from Hugh later on, but I think what you would have seen during the first surge very quickly, as Neil mentioned as well, that the local people, the clinicians came together, took the leadership. I think that is to be celebrated, the clinical leadership during the first surge, which brought so many changes so quickly. We are now much more digital savvy. We have virtual integration of services, although it may not be on the paper. We've got lots of people talking to each other, regions working in collaboration, patients going from one region to the other, one part of the hospital to the other, from independent sector to the non-independent to the NHS sector, without the bureaucracy that we are used to. And I think that is to be celebrated and to be retained if we need to maintain services going ahead. Staff, so we could have space, we could have systems, and we could have supplies, but I think staff is a real issue here. As you would know, we can't really grow trainees overnight. We can't really get specialists trained to their full capacity overnight. But also what we've realized during the first pandemic is that all those specialists and specialism is good, but there's got to be some amount of journalism amongst all of us, irrespective of whichever specialty we are in, to be able to deal with many other issues outside our domain, whether it's to support A&E, whether it's to support critical care, whether it's to support medical ward, a general ward. So I think those kind of programs which allow cross-skilling, getting to grips very, very quickly, is something that we have to have in our systems inbuilt going forward, so that if you are a surgical trainee or an anesthetic trainee or a trainee in an A&E department, you really know what else is happening in the hospital, and there is some element of cross-skilling going on all the time. So in the last few minutes, I think if there are take-home messages, and if we don't want to be in the same situation as we've been, we really need to first of all look after our staff, how best to make use of what we've got, because we saw in the first time, although some of the members of staff were very, very busy, but because large part of activity came to halt, some members could not be redeployed. They would come to hospital and would not get work to do, or would not find work to do. We shouldn't be in that situation. I think we should be planning a little bit better. Also, those who've been working very, very hard, and many of them are now quite tired. We hear from our members they're fatigued and there are issues with mental health. How best can we retain them, support them, and ensure that the impact on training and impact on continued activity is minimized? I think that's the challenge for us. So we need to be looking at that. We've got to celebrate clinical leadership and not let that go. I think more we can boundary bust, more we can rely on clinical leaders emerging locally to solve local problems, better we will be. So I think if we want to avoid what the problems of first surge, we got to be working more collaboratively rather than in isolation. So, and we are. I think last 6 to 9 months have told us, and that's one thing to take home is how easy it is for clinical leaders, if they become very, very active, to boundary bust and go across the boundaries and support each other. I think we've got to maintain that going forward. So look after space, staff, make sure there are plenty of supplies, and let's change the system. Thank you very much.
Thanks, Ravi. That was a very interesting way of looking at it all, actually. We're going to change slightly now, change tack slightly, and go from clinicians to executive, maybe. Hugh is National Director of Improvement for NHS England. I work in Wales, Hugh, so I probably won't listen at all. Please, crack on.
Okay, thank you, Sue. First of all, to say it's a great privilege to be here this evening and to join your discussion. I'm not sure my input will actually be very different to Neil and Ravi's. I think it sort of builds and complements what they've said. Both of them talked about climbing the mountain, and I think, you know, internationally, I was saying earlier, I was on a call last night with probably 7 or 8 other countries, and the impact we're living through a piece of history at the minute, which I think people will look back on and will have a fundamental impact on health services across the world. But not just health services. We know that it's impacting on economy, it's impacting on the way on our society in a whole range of ways. It's impacting on culture, education. And I think people will look back in years to come, if not decades to come, on this period and its impact for the future generation. And so it's a massive period in our history. It's a massive challenge. But it's also, I think, an opportunity. There's, I think, we know before this happened, our health services and internationally health services were under great pressure and strain. And we all knew and know, and I'm sure you've had conversations before about, and I'm sure Josh may well talk about sort of, threat of burnout, people being under pressure, our system feeling like it's driving harder and harder. And I think what this has done, we've seen actually some of the best of our people and some of the best of response. And I think we've had a lot of positive changes and people grabbing opportunities and doing things in a very agile way. And what we've got to do, I think, coming out of this is to make sure that we grab some of those opportunities. We make sure that the best of what our people have done, the best of the innovations, the best of the improvements, the best of the changes that we harness and we make sure embed so that the next generation can benefit from them. And it does give us an opportunity to make some fundamental changes to the way we've delivered healthcare. And I think that will be one of the things that will be judged by in future years. Could I move on to the next slide, please? I'm using this, which is a slide around, I've just done in the last couple of weeks around what my piece of NHS EI does, but I think it captures for me the sort of, I think, some of the challenges that we're facing. I've described it as probably there's 3 areas where improvement needs to focus on. And I think probably in many ways the NHS needs to focus on as we're coming out of COVID. The first is in around the recovery. We know that there's been a huge backlog developed. Neil talked about the waiting lists and the growth right across the NHS in each of the countries. And that backlog, the impact of working under different conditions, infection control conditions, means that recovery, and we know between the first wave and the second wave is trying to build services up again, that we have that huge backlog. So coming out of COVID, how we get successful recovery and get back to a much more even keel is going to be a major challenge for us. In terms then of the second area, what I would describe as productivity, and I'll say the term once because I've taken a paper to the board in the last week, and what I said was, the NHS has talked about productivity in a number of guises in several attempts and tried to improve the productivity of the NHS. But I think there's it's say the one time I will use the phrase, because actually I think when we set out to improve productivity, we often have a negative impact on quality and on staff. Because if you talk to frontline staff, and I'm sure many of you, when asked, you sort of hear the term productivity, think in terms of the engine being driven harder. We're already staff feeling very much under pressure, and productivity generally means to people, well, we're taking money out, or we're going to have to work harder and do more. But actually, I think that if we look at start from the other end of the equation, and this is where the sort of earlier slide I used was very much my Twitter handle. It's a picture of my Twitter handle, and I suppose my history, which is I've worked for the last 30 years at the delivery end. and this is the first time I've worked at a national level. And the things that I'm passionate about are patient safety and improvement, making services safer and better. I believe if we actually start from the point of view of getting the quality right, being much more consistent in our delivery of care, being much more consistent about offering the optimum approach more often, that our outcomes will improve, our quality will improve, the patient experience will improve, the staff well-being will improve, and as a spin-off, productivity will be better. Because actually, if you get quality right, you've less harm. IHI talk about 6 forms of waste in their analysis, and those forms of waste are things like harm. Harm every time a patient has an infection, every time a patient has a complication, every time we have an unnecessary test, an unnecessary intervention, unnecessary tasks for staff. All of those are forms of waste that add pressure and add cost to the NHS. So in my opinion, getting productivity right, you start at the other end of the equation, which is you get quality right, and the rest will follow. So for me, that's the how do we build, and at this time, with the backlog we have, we cannot afford to have the variation that we have right across the NHS. And that's variation away from the optimum way of doing things, away from optimum quality. We have too much variation, too much harm, too much inconsistency. So how do we get greater consistency in practice? The third area is what was the old special measures piece, which is those that are struggling. And my approach to that around is we want to, while we have statutory responsibility as the regulator, and for special measures, it should be much more what I would term about recovery support and how we support organizations and systems that are struggling. Underpinning all of that is the sort of having good data, having good analytics, having good benchmarking, having good tools to be able to improve, and also having understanding what are the beneficial changes that are happening in this time, and how do we build a continual improvement approach and culture. Next slide, please. So what's our response going to be in terms of next year and the approach to improving productivity? Sorry, has the slide moved on? Because mine seems to be frozen on. Ah, yeah, great, thank you. I think one of this looks a rather complex graphic, but it's trying to capture, I think, the way when we talk about the productivity piece, or actually getting much more, removing some of the variation and getting much more consistency in practice. I think the way we have typically done things in the past is almost, if you take the second level down, which is national programs or interventions, we've tried to manage those into the service. So we have a whole range of things around national programs, GIRF, outpatient programs, diagnostic programs, workforce programs, and we try and manage those down into the service, and people at the front line are trying to deal with this multitude of requests and asks. And actually the trick is the third level down, how do we take all those things that are proven to work or will be of benefit and build them into the optimum pathway? And that actually that what we need to be doing is delivering care much more consistently around the optimum pathway and designing a pathway. And that's been part of the work which has been going on in London. It's part of the work which GIRF have done in terms of hospital care, but we need to broaden that out so that it's the complete pathway. And what we want to do and are proposing next year is that we, instead of trying to manage down national programs into the system, that actually we embed the improvements that need to happen into a pathway, and that, as Neil and Ravi talked about, based around systems, that we actually implement the new pathways. So for example, instead of managing something like ophthalmology, in different sort of programs, that we'll actually have a complete ophthalmic pathway or a complete pathway for cataracts, which actually captures the sort of exchange of images from opticians to ophthalmologists, the referrals to advice and guidance, through into sort of following the optimum care and treatment, patient-initiated follow-up, digital pathways, all of these things embedded into a single pathway, and it's the Optum, which is very much owned and led by clinical leaders in the local system. And then the focus is on embedding that pathway as opposed to trying to implement sort of 6 or 7 different national programs. Next slide, please. Underpinning the approach, and I think which is really important to this, is having data, so that we're basing this on data and continual improvement. I think the other thing is, and we have been having quite a lot of discussions with different colleges and professional bodies around supporting they and clinical leadership must lead this process, must lead the development of the pathways, and working with systems and regions to make sure that the clinical leadership develops those and owns those locally. But I think, and one of the things I want to see, and I believe, is in terms of marrying up some of the improvement approaches and methodologies, the continual improvement, with things like GIRFT, so that we actually are able to deliver change on the ground. It's not just about the benchmarking, it's not just about saying, here is what good looks like, but how do we actually help people to make the change on the ground? How do we change the pathway? What needs to be done? How do we change the booking of a list? How do we change the number of patients on the list? What needs to be done in terms of the actual support pathways? So central to that will also be that we're devolving some more resource to regions and to systems to enable them to and particularly improvement resource to enable them to develop and embed the pathways locally. Where I see the national role becoming much more not mandating what people do right across the country, but actually is supporting that local improvement and local embedding, and particularly building the sort of connections. Both Neil and Ravi talked about the collaborative approach. So how do we build learning systems and systems that enable us to scale and spread much more successfully? That's a sort of a quick run through what I think is fundamental as we come out of the COVID period next year, is how do we actually reduce the variation and get much more consistency of practice. And by doing that, we will get improved productivity, but the real focus will be on getting better outcomes, better quality, and a better working environment for our staff and experience for our patients.
Okay, thank you, Hugh. You've all talked about staff so far, which I think is great. One of the groups, of course, that's been most impacted by the whole COVID pandemic are our trainees. And Josh, I'm sure you're going to give us some insight, if you would.
Yeah, thanks, Michelle. Good evening, everyone. I guess as per the previous talks have specified, it's vital that we continue to deliver surgical services with patients being at the forefront of everything we do. But with the college's lead in spearheading the recovery, we must do so whilst addressing the training crisis we now find ourselves in. Next slide, please, Misha. Way back in March when the pandemic began, we at ASIT brought together the presidents of the 15 specialty associations and vowed to continue to advocate and represent surgical trainees across all grades and specialties. Since then, every one of us has felt the effects of the COVID-19 pandemic. Many of us have been redeployed, supporting the COVID-19 efforts. Others will have worked as part of reduced surgical services, suffered the effects of the virus ourselves, or supported colleagues and relatives through the illness whilst adapting to a changed way of living outside of work. Next slide, please. Hugh mentioned how important having data is, and whenever a training issue arises, it's always easier to raise these with data to support the consensus which the specialty associations contribute to at ASIT Council. And so we set about measuring the impact of COVID-19 on surgical training. Phase 1 was through a survey-based collaborative study, COVID-STAR, with the specialty associations, and Phase 2, an analysis of ISCP logbook and ARCP outcome data, which we're currently working with the JCST on. Next slide, please. COVID-STAR reported the qualitative impact. It's quite a large data set, so I've just pulled out a few salient points in the hope that that highlights the gravity of the problem and generates some discussion. An electronic survey with 4 weeks of data capture over the months of May and June across all surgical specialties was disseminated through the association mailing lists and social media. Next slide, please. After removing the incomplete responses, we yielded just over 800 participants with a representative spread across gender, training grade, region and specialty. Next slide, please. And the results were non-surprising, with 41% of trainees being redeployed and 82% doing so on an involuntary basis. And this lasted greater than 4 weeks in 3/4 of cases and over 8 weeks in a fifth. Next slide. In 2/3 of training parameters which we measured, there was complete loss of training activity. This was around 50% in emergency operating, 80% in non-cancer elective operating, and this was compounded by loss of training opportunities due to dual consultant surgery in 43% of cases. Next slide, please. At the time, only 2/3 of surgical trainees felt confident to progress their next stage of training at ARCP, which was worrying. Next slide, please. Despite this, when we look at early analysis of data in the JCST, there are a huge proportion of trainees given a favourable outcome, with an average reduction in logbook numbers of 50%, so half, and in particular again in non-cancer elective operations. A fifth of surgical trainees received an outcome 10 at that last ARCP, and a worrying proportion of senior trainees are in this bracket. And if at the next ARCP these outcomes don't turn favourable, there's an obvious problem in the progression of senior trainees taking up consultant posts in the next few years. Next slide, please. Changes to exams reflected conversations with the college, ICBSE and the JCIE in terms of absolute numbers affected. And both the exam boards and the college have done an outstanding job in delivering these examinations, with a few issues still to work out around the future virtual MRTS Part A. Next slide, please. There's certainly no single solution for the training crisis we find ourselves in, but following agreements in England and Wales, access to private operating lists are likely to play a crucial role. And we're very grateful to the college for their role in establishing this and in reorganising the current contracts. However, early results from an ASIC poll, currently predominated by the general specialty, show that 6 out of 10, so 60% of trainees have had no opportunity to work in the private sector. Next slide, please. In 10% of cases, their access combined with home site operating they felt was inadequate to fulfil their current training requirements. And the main reasons offered were lack of information or pathways to accessing private hospitals and an inability to leave their NHS rota commitments. What have we learned so far? So with the exception of ophthalmology, surgery has been the most affected specialty across the whole of medicine, with alarming immediate risk to CCT. Consultant post uptake in the near future is really threatened. And although the poll numbers were only around 200, there's clearly more to do to optimise access to the independent sector. The COVID STAR study and the recent GMC survey showed burnout among surgical trainees is at an all-time high, which compounds a significant and sustained reduction in surgical training. One positive, as alluded to in previous talks, that's been identified, through necessity really, is the increase in the way we work and learn virtually, including the delivery of examinations. Next slide, please. So how do we sort this out? What is clear is that it needs to be a coordinated and combined effort from the educational bodies, the surgical royal colleges, institutions, trainees and trainers to mitigate the impact of the pandemic. JCST recently released a statement on how best this can be achieved with ASIT, BOTA and COPS. No training today, no surgeons tomorrow. It's not just a tagline. The numbers are really, really clear. Next slide, please. The key points. Surgical trainees must be protected from redeployment in order to maximise training opportunities through the optimisation of COVID light or green sites. Lead trainers, TPDs and the independent sector need to work together to facilitate trainee access, but this needs to be built into rotas to ensure that there's adequate cover so that the home sites are not left short. It may be that those at key progression points of CT2, ST7, ST8 need to temporarily be prioritised to ensure progression and to maintain the quality of our day one consultants. But I guess with active review of the situation for those in other training years. Communication from the college and exam board surrounding virtual exams will improve, but we must not lose the advances made on virtual platforms. Simulation has been suggested as an answer. Perhaps for more junior trainees, it might play a role, but we know already that there's huge regional variation in accessibility and we need to work to eradicate this. Undoubtedly, trainees need their trainers more than ever, and it's vital that both sides of the learning agreement make the most of every single training opportunity. And in the long term, we must ensure that any significant changes proposed to the surgical workforce are adequately evaluated prior to implementation. Next slide, please. Finally, a huge thank you to the English College, the specialty associations, including BOTA, who sit with us on council and the JCST, for continuing to listen to and work with the trainee voice. And thanks very much for inviting me to speak this evening.
Thanks, Josh. It's a lot to think about there, isn't there? I'll just start one question to you before we open up to the audience. What do you think about the senior trainees who are about to come off the end and start applying for consultant jobs, who won't have the numbers on their logbook? Should they be appointed to consultant posts and then mentored or supported by a senior consultant, or is there another option?
So currently there's no option for those trainees to CCT and take up consultant posts. Our last discussion with the JCST was very clear on that. The indicative numbers are not changing, so the level of day one consultant will not change. So I guess the question is well, how do we get around that? Does training time need to be extended? Can we make up that difference over the next few months and years, really? It's my understanding that the level of consultant won't change.
Okay, thank you. So unless you all have anything particularly to comment on, I was going to open out to the questions that we've got already and then see whether we have any more audience questions. Nicola, could you read the first question that's been sent in for us?
Yes, of course. So it's actually linked to what Josh was just talking about, and the devastating impact on training. What will the college do to ensure that trainees will have access to the independent sector when the current national arrangement ends?
Neil and Ravi, I think those are for you primarily.
We know that the current contract is finishing at the end of December, that the new contracts are in progress. We are in contact with those who are part of the negotiation, and we are pleading that appropriate provision will be made for the continuing prioritization of training opportunities in the independent sector as part of the contractual arrangement. It's early days. We don't quite know what exactly is going to happen. We don't know whether it'll be a part provision within particular hospitals. It's all still up in the air, but we're going to carry on lobbying for it like crazy.
Ravi, your trainees have suffered too.
They have, and the problems are not very dissimilar to what Josh has described. Talking about independent sector, and I think we have to, as colleges and academy, make as much noise as possible to make sure that the new contract does include the training opportunities or preservation of training opportunities. The other thing also, I think, is when we have independent sectors doing the kind of work where for craft specialties trainees, that is quite important. So one can imagine that you need more of training opportunities in some cases in independent sectors. But regional, there is a huge amount of regional variation. How much independent sector is utilized, what kind of work is done in independent sector. I think the contract has to take that into account as well. So regional variation becomes quite important.
Okay.
Thank you.
Hugh, presumably you've thought about this as well in NHS England.
Yeah, I mean, I think there's a recognition and acceptance that you know, training is such an integral part of you know, the sort of health landscape, and if we don't get that right, I mean, Josh has, you know, flagged up the report, sort of no training today, no surgeons tomorrow. And so, I mean, I think everybody recognizes the importance of building and strengthening training and development into our processes, because that is investing in our future. So, as Neil says, the detail, I think, is being negotiated through and being worked through. But I think everyone recognizes the importance of today's trainees getting the right opportunities, getting the right training, getting the right development, so that they will be effective in the future. So it is an investment in our future, and we have to get it right.
I mean, I hope those responses are slightly comforting, Josh, because I think everyone realises that the trainees are in a very difficult position, and I don't think it's going to be swept under the carpet. I think there is the will to support you through this. Do we have another question, Nicola? There was another one, I thought.
Yes, well, we've had a few in, so trying to sort of group them into themes. Should the CCT be based on competence rather than numbers?
That's one of my, I won't answer. Professor Mortensen, what do you think?
Oh, I think that's a bit unfair. I think you should ask Joss. I honestly, I'm really not sure. I mean, I think we're going to have to be very pragmatic about this. I think to say it's either one or the other, I think probably, maybe, perhaps, who knows, we'll get to a point where there will be some kind of compromise on competence, and there will be some kind of arrangement over mentoring in the early 1 or 2 or 3 years of a COVID generation surgeon's, if you like, early consultant post. But I don't know for sure.
Okay, I mean, certainly, Josh, I would think competence is the important factor. What's the view of ASIT?
Well, I guess the question is linked to how we measure that. And as long as the day one consultant standard doesn't drop, then that will be the right answer. I guess the new curriculums that are coming in next year are based on competency, and people can progress at a quicker rate than they previously would have done. And so it does support that theory that, you know, maybe we should be judging people on competence rather than numbers. But at the moment, the indicative numbers is the benchmark. And if we were to drop that at all, then there would be a fear that we'd be producing consultants who weren't as excellent as the current day.
But there are always trainees who become competent at, let's take gallbladders, having done 10, and others who are still struggling at 50 or 60. Numbers, I'm not sure that numbers are a good measure of ability as a consultant, but Ravi, do you have a similar system in anaesthetics?
So we are in process of implementing our new curriculum, which is more around professional outcomes rather than the competency-based syllabus. So we've moved away from, and our competency is a bit like numbers in our college, where have you achieved so many radial artery cannulations of this or that, whatever. So we are moving away from that. But my point really is that, as you've mentioned, every individual's learning curve is different, and we have a very straight. Traditionally, we've had a very straight jacket kind of training program where you spend 7 years or 8 years, and here you are a consultant. I think we've got to have some flexibility in the system, where if it requires more time, so be it. But if it means that you've got consultants who need a bit of mentoring in certain areas or support in certain areas, we should be able to provide that without having to stop them becoming consultants or progressing. So learning curves, and consultant is not just about doing a technical job, it's about doing many other things. So learning curves in all different areas tend to be different for different people, and we should be receptive to that and have some arrangement or systems to mitigate slow learning curves in certain areas.
Thank you. Let's have another question, Nicola, please.
This one is for Josh. What are ASIT's views on IST and the Extended Surgical Team project?
Juicy question. So today, the statement that we can make on IST is that it is no worse than CST, and we can't draw any other conclusions from the current analysis. As I alluded to at the end of my talk, any major changes to surgical training need to be done so in a way which is properly evaluated with demonstrable positive effect on surgical trainees. With regards to the Extended Surgical Team, we're currently at the point of recruiting trial sites, and I guess the hope is that that project is evaluated in such a way that we can declare that it has had a positive effect on surgical training. If it doesn't, then I would question its use and whether or not it should be introduced.
Okay, thank you. I mean, I think that's reasonable. Evaluate it before we move on and accept it as the way forward. I won't open that question out because I think that's very much a trainee's question. Nicola, let's have another one.
how do we mandate or restructure hospitals to have green pathways to secure training and safe access to surgery for our patients?
I think that could go to you for starters. Were you listening to that one, or were you writing?
I was starting to write some comments about it. I mean, I'll pick up the sort of how do we organize hospitals, and not specifically about the training piece, but I suppose the first thing, the answer was probably in the question. I think, how do we mandate? I'm not sure the answer is the mandate. I mean, I think at a national level, we need to have create the sort of strategic framework. We need to be clear about what it is we're trying to achieve. Talked earlier about the pathways. We need to have developed what the optimum pathway looks like. But I think we then need to, at a regional or system or local level, actually determine what's the best way to deliver that. I think if you look at successful organizations in any sector, they're moving away from a sort of traditional command and control, where the center issues a mandate around how it should be done. But the most successful organizations, and I think we've seen this a bit during the COVID period, where actually it is clear what the outcome is we need to achieve, clear what we need to have as a framework in place or an outcome in place, but actually the how has been left, that once that framework is created, the how has been left to much more local determination. What's the best way to deliver that locally? And that's not a charter for creating 230 different ways of doing something, but because I think there has to be some consistency, and I think that's where the framework comes in. And we will find that if we're clear on delivering the outcome, we give people the skills, and we give them the right environment to deliver those outcomes, I think we will find that there's much greater consistency of practice across the country anyway. And that's what we have found. And I think both Neil and Ravi mentioned about the importance of sharing and collaborating. So actually building that culture where people are actually learning from each other as opposed to trying to find their own individual solution. And I think that's part of the role of nationally, is to create those learning networks, those learning communities, so that we are sharing across the country. But I think, as in any sector, we're actually finding that having clarity about the outcome, giving people the skills, creating the right environment to innovate, and connecting people is the key to success.
Thank you. And Neil, you mentioned a strategic national plan. Do you think that we need more local flexibility, or do you think we can direct this from the centre? I say we. I mean, can it be directed from the centre, or should we have?
College has soft power, as we've discussed, Sue. And I think when we talk about a national strategy, I think it would be good if everybody could agree that what we need to do is reduce the waiting lists, number one, and these are the mechanisms by which we might do it, number two, and this is the way we're going to fund it, number three. It would be great if we got to that point. At the moment, I don't feel that there's any, if you like, sense of urgency over getting to that point. I feel there's a bit of a, business as usual and, business and usual plus, rather than actually let's really get to grips with this.
Okay, that's a provocative statement, but we'll move on from that. I tend to agree with you. Nicola, have we got probably one more question?
We've got a couple actually, so if people are okay, we can probably go just a few minutes over. What is the panel's view on the proposed reorganisation of services across London and the impact it will have both on trainees and current consultants?
Right, so I'm not sure that Josh, do you know much about that proposal to give an answer from a trainee's point of view, or shall I move on to the president's?
I understand the principles, but the granularity still isn't clear. So I will refrain from commenting for this moment in time, if that's all right.
Okay, Ravi, would you like to make some comments on that?
Where, and I've been part of discussions where people are talking about 2 or 3 things, principally having a regional approach within London, having hubs to decide what activity occurs where and what pathways are taken. It's a bit on GERFT model in a way that you have defined a pathway and you also then encourage a certain, as for example, all cataracts should be done under local anesthesia. So things like that are encouraged and the pathways are defined to reduce the variability, and there's a hub and spoke. I think the clinical buy-in is important, and I know that that's happening as more and more clinicians are participating in the discussions. Once this is agreed, I think this will be a good model because it's a model based on pathways rather than hospitals and their individual issues. I don't think it should have any impact on training, if at all. If pathways are running smoothly and if system is efficient, it should provide more training opportunities. So that's my view.
Okay, I don't think you'll disagree with that, Neil, or will you?
No, I don't think I will. Obviously, this is something that could produce a revolution in the way in which we organize ourselves. No longer I work for X trust, but I work for X, if you like, integrated system across many trusts. And maybe as a trainee, I'll go to trust X for my particular experience and expertise in a particular procedure, and I'll go to what was formerly a completely different trust, Y, for my experience in another kind of procedure. I think there's going to be some rationalization, if you like, of provision. It's very, very controversial. It could be actually very tough for some people on the staff of some trusts because they'll be asked to do things they haven't done before in other places. Those who are the advocates of it say that it's great for training because you get a volume experience on one site over a period, and then if we're talking about numbers anyway, that's good for numbers. Maybe in terms of competency, we don't really know its effect yet, but I think there is a head of steam behind it, and I think we will find that that's the direction of travel. That's all I can say at the moment.
Thank you. Nicola, we've got a last question.
Yes.
Sorry, Hugh, beg your pardon. I didn't include you in that answer, but please tell me what your thoughts are.
I felt, sort of the important maybe to comment on that one, because I'm picking up what Neil said earlier around, the state of the waiting list and the need for urgency. And I think I agree that there is a need for, and I maybe wouldn't disagree. I would maybe disagree that whether there is a sense of recognition and a need and an urgency in the need to address it, and I think that is recognised at a national level and indeed at a regional level. And I believe the London plan, the London response, is directly in response to that, which is we have to maximise the facilities, the estate, the people that we have, and organise it in the way which best deliver the outcomes that we want. And as Neil said, I think the idea that we just organise ourselves around perpetuating institutions or the old way of doing things, if there is a better model which gives us a better response to that backlog and that the current waiting list situation and our recovery, then we have to grab that. And that's part of, I suppose, what I was saying at the outset, which is I think there are some opportunities which will emerge through this period for us to do some things that perhaps we haven't been able to do for the last number of years or even decades. And I think we very clearly have a need to reorganize ourselves in a way which makes the best use of the beds and the capacity we have, and helps to release time for people to do what they want, in terms, which is, in the case of surgeons, do more operating, and we need to create the right model to enable them to do that.
Yes, I think a change can be disconcerting, but it offers an opportunity, doesn't it, to improve what we do. Nicola, next one.
So we've got one time for one final question, and just to say that thanks to everyone who has submitted questions and comments. We will capture all of those just so that people know that. So one final question to everyone on the panel. What does the panel think about the relaxation of the rules during the Christmas break?
Okay, let's go from left to right. Professor Mortensen.
I think that reluctantly I'm in the group who has been persuaded that maybe for psychological, social and morale reasons, a little bit of, if you like, relief is a good idea. I think probably it will result in a bigger, more ferocious tiered lockdown in January. I'm not quite with the group who say, you know, it's not worth turkey and Brussels sprouts. I think that maybe people need a little bit of relief. I'm comfortable with it.
Okay, Professor Mahajan.
Thank you. I think I'm going to be slightly provocative. I think it's we're relying a little bit too much as public, relying too much on government to tell us this is a time for lockdown, this is time to take things seriously, and this is a time when you can actually relax. I don't think there's a time to relax, whether the rules are relaxed or not. I think it's important that we all maintain safe distance, the social hygiene, all those things are important, whether there is lockdown or not. I think the fact that lockdown works and lack of lockdown has led to increased incidents is our own responsibility as well. I think we have sometimes let things go beyond those restrictions we should be following all the time anyway. So whether or not government relaxes, I think we've got to still follow the norms of protecting ourselves and protecting the public and protecting our near and dear ones. And so long as we do that, I'm hopeful that the Christmas will be all right, and we will come out of it without any further escalation. But if we let ourselves loose, then there is absolutely no doubt that it will lead to another surge, and that could be bad. So whether or not government has a rule or not, I think it's up to us. A lot of it is up to us.
Personal responsibility. Hugh.
Thank you.
Yeah, I think we've been offered as members of society an opportunity to have a little bit of a relaxation over Christmas, the opportunity to connect with those that are nearest and dearest to us, but to do it in a responsible way. And if we all do that, then the psychological benefits will be very positive. And if we do it responsibly, then the implications in terms of the sort of R number or the sort of post-relaxation impact can be minimized. I mean, I just a sort of personal aside, both my parents are in their 80s, and I've seen them once since last Christmas. And so the ability to be able to maybe see them for over Christmas in a sensible way, but recognizing that we still have to behave and take that opportunity in a very sensible and responsible way. Otherwise, the opportunity, I think, in the future, or the implications in the future, will be stark, that we won't get it. Why would we relax again in the future if we don't behave responsibly this time?
Josh, I hope you're not actually working over Christmas, but you could be. What are your views on the relaxation for the Christmas period?
I'm not working, luckily. First time in 3 years, which is good. So there's no asset stance on this, and I'm not a public health expert, but just because we can do something at Christmas, I guess, doesn't mean we should. And I think we just need to remember that there are other festivals throughout the year which haven't had that same relaxation. And I guess each of us has a responsibility to act in a way which we think best serves our the people we live with.
Thank you very much. Well, I think we'll call it. Is there any more pressing question, Nicola, that you really think should be asked?
No, I don't think so. I think that's probably a good place to draw things to a close.
Okay, well, I thank you, Nicola and Tom, for organising this, and Misha, and thank you all 4 of the speakers. It's been great. This has been a horrible time, but I think we've all accepted that there are some opportunities that have arisen as a result of the restrictions we've been put under, and let's just hope we can move on and use those opportunities to improve the service we provide. And the one thing I took from all 4 of you was, we can't work the NHS without staff, and it's absolutely fundamental that we look after all of our staff, trainees, consultants, nurses, even the managers. We need to look after them too. Thank you very much. It's been great. I hope you've all enjoyed this as much as I have. Good night. Have a nice evening.
Good night.
Good night.